It is my pleasure to introduce you to Dr. Lauren Mednick. Lauren Mednick is an assistant in psychology at Children's Hospital Boston and is on the faculty at Harvard Medical School. She received her BS from the University of Illinois and both her Master of Philosophy and her PhD in clinical child psychology with an emphasis on behavioral medicine from George Washington University. Her subsequent clinical, teaching, and research efforts have focused on helping children and families cope with medical stressors. The majority of her time is spent in direct clinical care, conducting outpatient therapy with children and adolescents diagnosed with acute and chronic medical conditions, including thalassemia. Dr. Mednick also has an interest in how a parent is coping impacts a child's physical and emotional well-being, and focuses much of her work on investigating stress and coping in parents of children diagnosed with various medical conditions. The Thalassemia Foundation is thrilled to be able to offer the experience and knowledge that Dr. Mednick has learned working with families with thalassemia, as well as with other chronic conditions. And now I turn things over to Dr. Mednick.
Thank you very much, Craig and Kathleen, for inviting me to come speak with all you. It's very different. I enjoy performing when I speak, and so this is very different. I'm by myself. I hope no one's walking by my office right now wondering what I'm doing. Anyway, so I was asked to do this talk and something related to child development, and as Craig said in his lovely review of what I do, I work with children with chronic medical conditions, finding ways to help them cope with different stressors. And I see kids with diabetes and thalassemia and urological conditions, and there's some things that are very congruent or the same over all these medical conditions, and then there's some things that are very different per different medical conditions. But I tried to think of what would be most helpful to parents of kids with thalassemia. And, you know, one of the things that I think people come to me in therapy a lot for is how to keep your child on track with following their medical regimen, with being cooperative. And so in that regard, I decided to talk today about helping your child cope with both medical procedures, and for you all, I'm mostly talking about things like getting transfusions, but it also might be getting different other kind of imaging or other kinds of tests that you have to get maybe on an annual or biannual basis. And increasing their cooperation with chelating regimens, because those are the two things that we ask your children to do quite often is get blood transfusions and chelate, and both things can be a real pain and can be really difficult for kids. So here are the two goals that I have for today, and the first is just to learn tips and strategies to use to help your child effectively cope with medical procedures, and then to review strategies to increase cooperation with daily medical regimens. And the idea is that research has shown that with experience, and if children have poor experiences as a child, if individuals have bad experiences as a child with medical interventions, with having a lot of pain, this will influence their experiences as adults. So they've actually shown that adults that have really traumatic medical experiences as children avoid medical care as adults. So it's really important for their functioning now to help them cope with painful medical procedures and understand why they need to cooperate with these things, but it's also helpful in the future. So this next slide shows typical reactions to medical procedures. So that we're first going to talk about the medical procedures, and I'm sure you all at some point, I'm sure there's all different age, parents of all different age kids here, but I'm sure you've seen many of these reactions from your children. And these are very normative and age-appropriate, many times, reactions for kids to have when somebody's coming at them with a needle. So just to review, the common reactions of children getting an invasive medical procedure, and invasive medical procedures can be anything from a needle poke, just for a blood draw, to getting a blood transfusion, to getting an MRI, anything that they view as getting in their space. So the first group is what I'm calling overt or active, and this is crying, resisting treatment, destructive to the environment, and I actually believe that I enjoy when kids do this one. And nurses will look at me and say, what are you talking about? But the reason I like when kids have this overt or active reaction is I know they're distressed. and they are telling me with their behavior that this is scary to me, this is painful, this is difficult, and so I can know that they need some intervention. So this is not something that I avoid. I actually like when kids do this. These are sometimes the kids when it's very extreme, and I will talk to you a little bit about what's extreme and what's not. When it's very extreme, that these are the kids I get called to see, and so we don't miss them. Whereas kids that have more of a passive or regressive reaction, so passive being decreased eating, not wanting to talk as much, kind of withdrawing, and regressive being, temper tantrums, all of a sudden sucking their thumb again. They were toilet trained and now they're having accidents. They're more clingy to their parents when they were independent before. These don't cause as much distress in the hospital environment because these kids tend to still be cooperative. And so sometimes we miss that they're having a difficult time. It's actually, I often rely, and the medical teams often rely on you parents, the parents report to say, something's wrong with my child. She usually has a much better appetite, and since we've been starting with transfusion, she won't eat. What I do want to say here is that most kids, younger children, most kids, I'd say under the age of 8 or 10, are going to get upset, and especially the first few times they get transfusions or get needle pokes, and they're going to cry, and they're going to have a difficult time, and I actually think that's totally normal behavior. If they didn't cry the first 5, 6, 8 times I came at them with a needle, I'd be very concerned. And what I'm looking for when I'm thinking about is this reaction excessive is how quickly they're able to be to calm down after a procedure. So are they crying for hours after they have started, the transfusion was started, or is it 10 minutes and then they're fine and they move on? And also, can they be comforted by their parents? Are they reassured by their parents? Do their parents make them feel better? Or, they're going to be crying for 4 hours afterwards anyway. And just one other thing I'd like to say about older children, oftentimes I've seen that older kids will often get upset. And what I start to talk to when kids can understand this, so when they have some cognitive maturity, maybe around 5 or 6 years old, is I say it's okay to scream and cry. It's okay to be upset as long as you cooperate. So I had a little girl that I actually went with to get a blood draw recently. Her name is Jillian, and we went down to the phlebotomy center, and she looks at her mom and she says, "Can I scream?" And her mom said, "Sure." And so she screamed, but the whole time she had her arm out straight and allowed the nurses to do what they needed to do. And we talked about afterwards how it's okay to scream as long as you remain cooperative. So please, that's something to take from this, that having your kid cry or be upset is not abnormal. It's the degree often and how quickly they can recover, and then also, can they still at a certain point be cooperative even if they're upset. So this is sort of a joke. I said this is the goal. I think there's very few kids that are going to even, well-experienced kids that have gone through 3 dozen transfusions that are going to walk in and look at the nurse and smile and lift their sleeve up and be so happy about getting some sort of medical intervention. But I think what I'm trying to get at with this slide is that the goal is to move towards this, to have your kids be less upset when they have a medical intervention and more accepting of it and less distressed. So I'm just going to talk about, I thought the best way to handle perhaps the rest of this talk is to talk about some general little pointers and tips that I give with parents over many, many times meeting with them, or over many lectures that I might give to a group, but just some general pointers you can kind of take home with you today, or I'm assuming most of you are already home, so you can keep home with you. So the first is to talk about the importance of honest communication. And children who are given information that turns out not to be true often develop distrustful relationships with parents and or the medical team that will negatively impact future reactions. So I'll give you some examples. I have heard of, and I've had examples of parents saying to kids, rather than telling them they're coming into the hospital for a procedure or a transfusion or what have you, saying, "Come on, let's get in the car, we're going to McDonald's." and lo and behold, they end up at Children's. And, what I always say to trainees I work with and nurses that I work with so they can understand where this comes from is that I don't think the intention there was to lie to your child. The intention was to develop a distrusting relationship. The intention is always good. The intention was, I need to get my kid in the car, I need to minimize stress, I need to get going. But what happens in the end is now every time the child gets in the car because the mom says they're going to McDonald's, now they're freaking out because they actually think they're going to get some sort of medical intervention. And so it's actually as much as we sometimes tell little lies in order to help kids cope in the moment, for the future, it's not going to be very helpful. Something that doctors do quite often is they will say to kids, this won't hurt at all, which I have a problem for many reasons. One is pain is a perception. So how do you know it's not going to hurt? It's my perception if it's going to hurt. But I also feel like then when it does hurt them, they're never going to trust doctors again when they give them information about something. So it's really important to set up as honest of a communication chain as possible. And so, I said, to avoid them developing these negative feelings towards the medical team and distrustful relationships, they need accurate, minimally threatening descriptions of what they will experience. And I will talk a little bit about, first of all, when to tell the child about a procedure, and also what to tell a child about a procedure. And I do recognize that many of your children are going through frequent medical procedures. Every 3 to 4 weeks they're getting a transfusion. So, and some of them might be older, and so that they know that every 15th of every month they come in, and so this might not apply as much about when to tell them. But for younger kids who don't have a good sense of time, you might benefit from these guidelines about when to tell a child about a procedure. And for older kids that perhaps it's a procedure that's not a regular procedure, perhaps they're getting an MRI or some sort of other other type of invasive medical procedure that's not typical for them, but they occasionally have to do, these guidelines might be helpful. So in general, and I think I also want to say even before I go through this that, a goal I have as a psychologist, and I always work with parents, is that we need to be flexible, that these are general guidelines, but that every kid is different. Every individual kid is different. There's some young kids that this guideline would be ridiculous for, and some teenagers that this guideline would be ridiculous for. But in general, research has indicated that young children, so children before school age, I would say before the age of 5 or 6, telling them about a procedure 1 to 2 days before a procedure is usually the best amount of time. This will allow them not to create too much anxiety and come up with distortions and fantasies about what's going to happen, but it will also give them a little bit of time to ask questions and adjust and not be, surprised. This also helps kids not giving them too much time in this young age group because they really don't have a connection with time. You tell them 2 weeks and they don't understand what that means. And so usually telling them a day or two before is helpful. For school-age children, it's more common to tell them about a week in advance. And mostly this is because developmentally they have a better sense of time. They are more mature and are going to have more questions to ask, and they're going to need more time to kind of process this. And then for teenagers in general, teenagers are usually involved in treatment planning and know when something's coming up and have been in all the appointments and heard all the doctors say things and are moving towards maybe gaining some independence and some autonomy over their medical condition, so you want them involved. Again, I just want to stress that I have some young children who, know way in advance and do okay with that, and I even have teenagers who really feel like there's certain information that they don't want to know until a couple days before, and they've sort of worked out that system with their parents and it works for them. And so I don't think there's a strict right and wrong here, but this is a general guideline that I use with kids. So an important question would be what you tell a child about a procedure. So, you're telling them they're getting this, but what do you tell? And back to the honesty thing, I'm always going to use honest information and simple explanations that are developmentally appropriate. And, sometimes this is difficult for you to know what to tell them exactly, and hopefully there's folks if you're not at my hospital, you're at another children's hospital that has folks that can help you if you're struggling with what's developmentally appropriate. I typically, and this will give you some more guidelines, I only describe to children what they're going to hear, see, smell, and feel. So, for example, I had a little girl in my office today who is getting a very major back surgery next week. And she's actually a school-age child, so we told her about a week in advance. And we were talking about it, and she was asking questions, and we spent some time discussing both what would happen before the procedure and what would happen after the procedure. I didn't spend almost any time talking about what would happen during the procedure, the surgery, because for her, she'll be asleep. And she doesn't need to know the details of the kind of scalpel they're going to use and the stitches they're going to put in and what they're going to remove, because that's just going to increase her anxiety, and she won't really be alert during that experience. For children that are getting a transfusion, we would need to explain to them, and then the tube is going to stay in your arm, and, it might be hard to use that arm while you're sitting in the chair, but, you remember you had it before, and, with kids that have had these procedures over and over again, obviously you won't need to keep explaining this. But there are things that come up, I know, with medical care, with caring for kids with thalassemia that aren't as regular, and they'll need a little bit more preparation about what happens before and after. I really like to stress the idea of talking about what's going to happen after the procedure. And my reasoning for that is oftentimes kids don't know, and even young kids, the first few times you might come to get a transfusion when they're cognitively aware what's going on, they think this is their new reality, that, we forget to tell them, and then when the transfusion's done, you get to go home, and we're going to take the tube out of your hand, and it's not going to stay in there all day. And, we forget so often that kids need those basic pieces of information. So especially if a child is ever hospitalized and they've never been hospitalized before, talking to them about that this is not a permanent thing. Younger kids would need this information that eventually will go home, and we're not living here now. The next point is avoiding reassurance that includes potentially false or vague statements. Parents oftentimes, want to say to kids, you're going to be fine, this is no big deal, or a vague statement like, I'm sure saying things that, isn't very clear. Kids want concrete information about what's going to happen, and they want to be told the truth. So in general, you just want to avoid those things. I think something that's, really important is to always answer questions honestly, and this comes back to the honesty slide from before. And, in conjunction with that, it's okay to say, I don't know. So often we think that when kids ask us a question, and just in general, we have to give them an answer. And just like when we ask kids questions, sometimes they don't know, they say, I don't know. It's okay for adults to say that too. And so if they ask you something that you truly don't know the answer to, or this is a great excuse to use the I don't know when you say, I don't know how to answer that question. For example, I've had kids in the hospital ask me very complicated questions, ask trainees very complicated questions about kind of how this will impact their life in the long term. And I say to trainees, it's okay to say, that's a great question. I don't know the exact answer, but we're going to talk to your doctor and we're going to find out. And kids accept that. They accept that we don't know everything. If they say, is it going to hurt? I often say, I'm not exactly sure how it's going to feel for you. Some kids say that getting an IV pinches. Other kids say it burns for a minute. And other kids say it's not a big deal. And we're going to let you decide. And you're going to tell me how it feels for you. Another thing that I tend to do when I'm telling kids about a procedure is I ask for a repeat back. So, if they're getting an MRI and they're not used to doing this, I explain to them how the machine's going to work and that it's not going to hurt, but it's noisy and this is what's going to happen. And I ask them, can you tell me what's going to happen tomorrow when we go for the MRI? Or can you tell me if your doll was going to have the MRI, what would happen? Or if your friend asked you what's an MRI, what would you tell them? And the reason for that is, one, is when kids repeat what you said, it kind of solidifies for them, and it helps their learning of the concepts. But also, it helps us correct misconceptions. Often, when they're repeating it back, it is not accurate what they tell us, so it's helpful to hear what they heard. So general tips for helping your child cope with a medical procedure. One is to stay calm and confident in front of your child and take necessary breaks. Kids look to their parents for how to react to something. So if you are very tearful and having a really difficult time because they're being poked 2 or 3 times to get an IV started, and they see that you're getting upset, they're going to get upset. Kids of all ages look to their parents, especially in uncertain situations. So it's really important. I'm not at all saying that it's not okay to share with kids your feelings. When they say to you, it stinks having thalassemia, that you can't say to them, I know, I agree it stinks having thalassemia, and that you can't show them your card sometimes. But in a stressful environment of getting a medical procedure, that's your time to try to hold it together. And it's okay to say, I'm not the best person to be in my room with my child during this procedure because it's so upsetting for me. I'm going to have my wife or my husband or his favorite nurse or child life specialist, because when I'm in there, it's more difficult for my child. And recognizing that is a wonderful thing that you can give to your child. I always encourage, one thing that parents can do is encouraging your child to share their concerns and to talk about, is there anything that worries you about this, and keeping open communication about medical procedures and how they feel, but also medical illness in general and having thalassemia. Identifying, responding, and validating the feelings of your child that they're experiencing. So oftentimes they might not recognize that what they're feeling is anxious or sadness, and so helping them put words to it, identifying it, but also validating it, that, like I said, when they say, I hate thalassemia, I wish I didn't have to do this, it's okay to say, okay, I understand, I wish you didn't have to do that too. The next piece is, but we have to. But it's okay to validate that it does stink to have have this medical condition, and it does stink to go through these things, and it's not fun. And, saying to them, it's not a big deal, isn't really fair, and validating that this is a hard thing for them. When possible, I try to encourage parents to attempt to give their child a sense of voice and control, so providing choices to kids. And we'll talk about this a little bit more when I talk about chelating, about choices. But, giving children a sense, there's a lot of things they don't have a choice about. They don't have a choice about getting a transfusion. I'm sorry, you're getting a transfusion. But could they have a choice? Could they have a choice between right or left arm? Maybe. Could they have a choice if they get Emlixemen on before or not? Yeah. Could they have a choice whether they watch a movie or do an art project afterwards? There's lots of things that they could have a choice about. Stick to normal parenting routines. So it's important that parents maintain rules and limit setting to a certain degree, because when kids really relish in that and really thrive in structure and routine, and when parents take that away, it really sends a message to kids that something's really wrong with them and something's really terrible because my parents aren't even making me do these things. And then the last thing I say is to teach problem-solving skills related to treatment. So, and that's talking about what's difficult for you, and let's think of a way to make it easier. And if one of the reasons they hate, getting transfusions is because they're bored, can we make a list of fun things you can do? And so there's ways to problem solve around how to make things a little bit easier for them when they're getting a medical procedure. And there's also, many staff members, child life specialists, psychologists, social workers, nurses that can help with this problem solving. So just to talk for a couple minutes about specific strategies to help your child cope. So this is, I'm going to talk a little bit about medical play, and this is something where it can go one of two ways. One way is to have a child to demonstrate a procedure to a child. So this might be right before the first time they're going to maybe chelate, we bring out a doll and we show them if they're going to do death sprawl what it's going to be like, and we actually practice with the actual medical equipment so that they can learn something. Another way, and which is more common with kids, is to allow them to familiarize them with the equipment and make it less threatening by allowing them to play with the medical equipment in a way that they want. And so oftentimes these are kids that are giving these poor dolls needles in their eyes and different types of interventions like that. And really what it's doing is making this less threatening, making these equipment less threatening, and familiarizing with them. And this is particularly helpful for young children who learn best through doing rather than talking or even seeing, that they actually need to have their hands on things. And so this is something that parents can encourage their kids to do. You can buy a doctor kit to have at home so that they can help take care of babies and yourself. And these are obviously for younger kids or, you know, act out what's happened to them. But you could also, in the medical environment, you can ask the child life specialist to do medical play with your child, and that could be involved real medical equipment or play medical equipment. And this is just, these are actually, most of these pictures come from, I do a lot of international medical work preparing kids for cleft lip and cleft palate procedures. So these are some kids in this slide from Venezuela, or no, this is from Bolivia, and they are putting this kid to sleep with anesthesia and doing medical care. I didn't put the picture up with a little boy who's getting anesthesia, has his legs crossed, and yeah, they're very funny. All right, so another specific strategy that, and I would like to say that this is probably one of my biggest take-home messages at all ages. Distraction is an amazing tool that parents can use. You don't need training to use this, and it makes such a difference for kids in anxiety-provoking situations and painful procedure situations. So what distraction is it involves the purposeful refocusing of attention from a threatening situation, so getting a needle, to a less threatening situation, or less threatening thoughts, objects, sights, or sounds, while staying in the situation that's scary. So you're not going to leave, we're not going to avoid getting the needle poked, but we're going to take your mind off of it. And the idea behind distraction is that we only have a finite amount of attention. And if we can put some of our attention on a distractor, then we have less attention left for the anxiety-provoking stimuli. And, you know, adults use this all the time. This is for all age groups. And I'm not going to go into this literature, but there's a lot of discussion about the difference between active and passive distraction. So passive distraction is watching TV. Active distraction is, for example, doing a word puzzle out loud, talking about it. And both have their benefits, and you know, you can kind of see which works best for your child. But, you know, one point I want to make here is there's a research study that looked at kids. Some parents were asked to reassure their children, and you're going to be fine, you're going to get through this is okay, hang in there, you know, this will be over in a minute. And then other parents were asked instead to distract their kids. So when their kids were complaining, they had a pop-up book and they were trying to get their kids, or, you know, we're doing word puzzles with them, or we're trying to get their kids' attention away from the anxiety-provoking situation. And what they found was the kids that received the distraction were coped much better with the procedure, reported less pain with the procedure, had less anxiety afterwards, recovered more quickly. And the reasoning is that reassurance, which is something that's just innate in many of us, what you're doing is you're refocusing the child's attention on the scary procedure rather than getting it off of the procedure. So distraction, distraction, distraction. I can't say enough about it. And the reason I just love it so much is, like I said, you don't need to go get your PhD in psychology to learn how to use a distractor with a child. And so the next slide, what I'm going to be talking about is age-appropriate distractors with children. So with age-appropriate distractors, and with infants, I talked about rocking and sucking, a pacifier, toys with lights and sounds and vibrations. Little kids love that stuff. I'm not going to go through all these, but just, you know, you can see this list that as the child gets older, you're doing a little bit more involved distractors. So with toddlers and even young school-age kids, bubbles. I mean, I'm sure whether you have young kids now, you've tried this, or the child life specialists have tried this, or you can remember when your child was younger. And then with older children, there's wonderful things like, you know, just having music and video games and doing riddles and math problems. With this little girl who said, "Can I scream?" We did math problems, and she just did beautifully. She's 6 years old, so for her that was great to do some math problems. All right, we can switch the slide to the next. And the next slide, I'm talking about specific strategies to help a child cope. And this, again, and I'm talking about reinforcement, and so this is the last thing I'm going to talk about when it comes to helping your child cope with medical procedures. And the idea with reinforcement is by pairing a positive outcome with an aversive stimuli, with something the kid doesn't want to do, the child develops a positive association with the aversive stimuli. So I often say to parents, well, you go to work, and that might be your aversive stimuli, and then you get your paycheck at the end of the week, and there is your reinforcement and your positive outcome. And so it makes the aversive stimuli seem a little bit less negative. And I really try to refer to this as a motivator and not a reward. And the reason for that is I don't want, many times parents are really reticent, are really uncomfortable with rewarding their children for doing things that kind of is expected of them, even though it's hard. But oftentimes younger children need an external motivator, or even some older children, to really cooperate and to make the experience more positive. I know we had kids that used to come to our clinic that the parents were sort of anti-McDonald's. And however, what they started doing was every time the kids, they were probably like 5 and 6, came in for transfusions, they were allowed to have McDonald's. So, once a month they could have McDonald's. And all of a sudden, coming to get transfusions became sort of this fun, exciting thing rather than this really terrible thing. Next slide, please. So I'm going to switch gears a little bit now. So that was my brief talk on procedures and how to help kids cope and manage procedures and help parents a little bit. And the other big piece of thalassemia care, as you all know, is chelators and doing chelation. And now there's so many kids on oral chelators, but there's also still a lot of kids on Desferal. And so I will try to be cognizant of both of those things in discussing these tips I have, and I think they can be used for both methods. And I'm getting a lot of this from an article that we had written in a pediatric hematology journal about why oral chelation isn't always the greatest method for younger children. And so that's what this slide is talking about. And I got the ideas that I'm going to talk about for increasing cooperation below here actually are talked about in this article. However, they can be used for increasing cooperation with anything. So the reason that I think in young children, so in children I would say 5 and under, that oral chelation can be really challenging is that it doesn't mesh well with the demands of that age group. So, for example, young children often have oppositional behavior, so it's going to be really hard to get them to cooperate with something that's going to take their motivation. We can't just kind of stick them with a needle. We have to get them to cooperate to drink this fluid. The other piece is that, with oral chelation, you have to stick to a pretty strict schedule and routine around, you have to drink this fluid, on an empty stomach, and it has to be done in a certain amount of time and in a certain kind of liquid. And this can be really tough. Kids in this age group have finicky and erratic eating behaviors and habits, and so getting your kids to adhere to that is going to be really hard in the younger age group. And then I think the third thing is that, I've heard from some kids that there can be a funny taste or texture to an oral chelator, and this sensitivity to textures and tastes is really prominent in kids under 6. And so, my point in saying this is that I think with the advent of oral chelation, this really improves cooperation with a lot of, and improves adherence with a lot of people with thalassemia. But in this really young age group, it might make things harder for parents. So some of the suggestions that I give is that, one thing to just consider is that maybe Desferal would be okay for your child until they can understand treatment options and the importance of adherence. So when they can understand, oh, there's a choice. I can either get a needle or drink this. Most of them will make a choice, drink this. So, but if they don't have that understanding, it's going to be hard to get them to cooperate. And like I said before, with Desferal, we can sort of implement adherence. We can kind of force adherence on them. And with drinking something, you can't, shove something down a kid's throat. It's impossible. And wouldn't be appropriate. And, the second suggestion I'd have is to kind of consider, if you really are wanting in this age group to really work on oral chelation, that's fine, but just consider it kind of a low-stress trial to see if oral chelation is appropriate for your child, if they can manage to be on the stricter routine as a young child and the texture and taste aren't going to bother them. And if it doesn't work, then, thinking about moving to death for all until they're a little older would be appropriate. Next slide, please. In the next slide, I'm talking a little bit about increasing cooperation with providing choices. And again, I'm talking of this both with oral chelation and with death for all, because yes, we can force cooperation with, we can force a kid to adhere to death for all, but cooperation is different. They can still run away from you. They can still kick and scream and run, not allow you to not sit still, so you can't give them the poke. So it's definitely helpful to have a cooperative kid. So giving kids choices, and I talked a little bit about choices in the earlier part of the discussion, it provides kids with a sense of control, and having a sense of control makes a huge difference. And one thing you want to, because again, you can't, it's not do you want to do your key later, but we could say how do you want to do your key later. Open-ended questions aren't as effective as providing kids with concrete choices. So an open-ended question is, what cup do you want to use? One thing that I hear doctors and parents do all the time is ask their kids open-ended questions that they're not okay with the answer. So, do you want to do your chelation now? Oh, well, what happens when they say no? Then if you don't listen to them, now we're into the trusting again. Uh-oh, we're doing something that's going to cause a distrusting relationship with our kids. So it's important when you ask a question, you actually are okay with the answer. So that's why I love forced choice questions, because really, as parents, you can choose two options that you really don't care which the kid chooses, but it allows them some sense of control. So do you want to use the red cup or the blue cup? Do you want me to poke you in your right leg or your left leg today? Do you want mom to do it or dad to do it? Do you want to start your death for all now or in 5 minutes, if you don't mind if it's now or in 5 minutes? And so when you're giving kids the choices, I said this before, you want to just make sure that you're comfortable with whatever options that you're going to give the child to choose. And it looks like I already gave several of these examples. One of the, there's so many different choices you can give them. But like I said, I would stick to giving them a forced choice and choices that you are okay with. Next slide, please. So the next one is about increasing cooperation with making medication taking fun. And so this is a strategy that I'll use with a lot of kids to increase their adherence and increase their cooperation. So oftentimes, especially in the younger age group, they'll start to think that medication is a punishment, that, I did something wrong and this is why I have to do this. And, it's a whole other topic of how we can work with kids to give them age-appropriate information so that they don't have that misconception. But to combat this thought and to make medication not feel like a punishment, whether, feel like a punishment or actually in their mind be a punishment, I try to turn medication taking into a fun activity. And this is probably especially useful for things like drinking an oral chelator, which takes a few minutes. And so one thing that you could do is play a game with your child. So, for example, a younger child may be Candyland, an older child may be Uno, and every time your child takes a turn, he or she needs to take a sip of their medication, with the idea that at the end they're finished their oral chelator. With death for all, there might be other kinds of games that you can play around, making it a little bit more fun. Another good idea that we could do with, in particular with the oral chelator, is a game that I call Race Against Time. And oftentimes I'll use like a sand timer with kids, and I'll say, I want to see if you can finish this before the sand runs out. And this isn't particularly helpful for kids that don't have a good sense of time because they're given a structure now. It's when the sand hits the bottom, I have to finish this. But you make it sort of a contest. You can also just use a digital clock if kids understand, numbers and can understand when a number changes. Next slide, please. And this next one is about increasing cooperation using rewards or motivators. And again, I talked about this a little bit about how we can make getting a transfusion or coming to the hospital have a positive association by using a motivator. But we also can increase cooperation using a motivator. So the goal of a motivator, really importantly, is not to bribe your child to cooperate, but rather to increase cooperation by creating a positive association with adhering to the medical regimen. Like I said, adults often need external motivators to move forward. Getting a paycheck is the most simple thing that adults do. I often say to parents, I do love my job and I love what I do, but in the end of the day, it's the paycheck that I think if we all were independently wealthy, most of us would work at least a little less. I think as far as prizes go, they can definitely be material objects, so stickers or a small piece of candy. They can be earning a privilege, so being able to watch a TV show or stay up a few minutes later, or earning special time with parents, special game time or something for cooperating. There's so many different rewards, and as kids get older, they likely won't need kind of an external motivator. They'll understand, I need to cooperate because this is going to help my health in the long term and help me live a long, good life. But younger kids, even school-age kids, even adolescents often, they don't either understand that or believe that, and so we often need to find another way to motivate them. It's really important that the reward is something that would be salient to the child, and what I mean by that is something that they would want. So an example would be if I was going to say to a child, every time you take your medicine, you can have a Hershey Kiss, and they don't like chocolate, they're not going to be very motivated to get that prize. So you want to make sure it's something that's motivating to them, that's salient to them. The other side of that is we want to make sure it's a reward that they wouldn't receive otherwise. So the family that, for example, with the coming to transfusions that was trying to make a positive association, who was giving their kids McDonald's once a month when they were here, if they went to McDonald's all the time, it would lose its fun. It would lose its motivating factor. So if you're going to try to reward your kid with TV time, but they can watch TV all the time anyway, the kid's smart enough and they're going to realize, well, why would I agree to this? Because Mom will let me watch TV tonight anyway. And often I've had this, the TV thing is often a plug for a lot of kids, in particular in families where TV is not something that's readily accessible, allowing kids to have a short period of time for cooperating with their stick or whatever, that you get a half an hour of time every time you get poked, often can really motivate a child if that's truly the only time that they can watch TV. And then something, just developmentally to keep in mind is that young children, so, preschool age and even school age kids, and just depending on your child, you have to kind of see, but they'll need a small reward after each time they cooperate. So younger children might need, a Hershey Kiss after every time they get poked, or after every time they take their oral chelator, or might need, a little something, because they kind of can't remember and associate the award with the actual cooperative behavior. And as kids get a little older, in school and stuff, and adolescence, of course, they can recognize, they have the ability to have delayed gratification, and they can understand, oh, I'm earning points towards a larger prize. And so oftentimes that's when you think about something like a sticker chart or a point system, where if a kid earns a certain amount of points for cooperative behavior, they can go and pick out a new stuffed animal at the store, or they can stay up on Saturday night and watch a movie. So just, keeping in mind that every kid is a little bit different. Next slide, please. And so just a couple more things. So other tips for increasing cooperation in general is that it's really important to develop consistent, predictable routines around medication taking. And so kids, like I said earlier in this talk, really thrive, all age kids, on some consistency and predictability. And so, if the way you set up the medication and take the medication and do everything is, always at the same time and in the same place, it's helpful for kids to it's comforting and it's predictable and it's nice for them. And then also, kids really thrive on attention, and kids will take positive or negative attention. They're not picky. And so it's important that we really lavish attention on good behavior and positive behavior and cooperation, because then we'll get more of that behavior. So when a kid is doing a positive behavior, engaging in cooperative behavior, giving their child positive attention often will increase that behavior. And just the opposite, giving them any kind of attention for negative behavior often still increases that behavior. So it's really important to really, lather on attention when a kid is doing something positive. And then last slide, please. This is my last slide for today. Talks about I really, in working with kids with chronic medical conditions, it's really important to me to kind of end on the note of, we're often talking about how vulnerable these children are and how they're more likely to have this and that, and they have to deal with so many complications and so many hardships, but really there's a lot of really wonderful things and extra special skills in strengths that kids with chronic medical conditions have. So this is just a list that I really like to end on in a lot of my talks, and just that many of these kids have an extra special maturity and insight into what it's like to be different. They're usually more socially competent because they've worked with adults and nurses, and they have to understand things in a different way. They're very loyal and value their family in a different way than other kids. They're tolerant. They're proud. It often affects their vocational direction. You often see these children wanting to go into helping professions, and they learn how to be advocates for themselves because they see their parents and their nurses and their care providers advocating for them all the time. So despite having some vulnerabilities and some hardships, your children all have really wonderful strengths and wonderful things about them and advantages too. So that is, I guess, ending my talk right now. And Kathleen, I know you had sent me a couple questions, but I don't know if you had gotten any more that you wanted to send to me.
Let me see here. I haven't gotten any tonight. So if anyone has some questions, please send them into my email, k.durst@cooleysanemia.org. But for now, I think those are the only ones for now.
Okay, so maybe I'll just spend a couple minutes talking about the theme of these questions, and then we'll end, I guess, with the quiz again. Is that right?
Yep, perfect. That's right.
So, I'm not going to, somebody had emailed in some questions, and I think the general theme of these questions were about how to talk to your children about sharing their information, their medical condition with their friends, how to deal with questions that their friends might ask them, why weren't you in school, what's going on, what to tell teachers. And really, I could probably spend another hour talking about, advantages, disadvantages, how to do this, what to say, when to say it, different age things. But I think the general take-home message that I'd like to give you all is that I think the skill is in helping your child find a balance between maintaining some privacy, not having to be the poster child for a medical condition unless they want to be. There's definitely kids that will go out and do all the walks and want to raise all the money and tell everybody about their condition. And if that's who they are and what they're comfortable with, that's fine. But helping them find a balance where if they want, they can maintain some privacy, but also not have so much secrecy around their medical condition that it appears that there's something to be ashamed of, and there's something shameful about and secretive about having their medical condition. So oftentimes when kids come to me, we talk about, and they haven't told a lot of their friends, we talk about, well, do you have a best friend you want to tell about where you go every week? And what do you want to tell them? And we talk about using very basic terms and not getting into huge details unless, as the kids get older, they might want to. But, it's often helpful for kids to have a friend or two who knows what they're going through, have an adult, one teacher in the school understand or tell them about it and not feel like it's shameful. In one of the side questions in this was, how do you answer questions to kids about, why do I have thalassemia and my sister doesn't, and all these types of things, and feeling isolated. And I think, I guess the last big piece of advice that I'd like to give is that I think something that's been so helpful with the kids I've worked with, both with thalassemia and other medical conditions, is meeting other children that have similar medical conditions. If, in the THAL group, we could probably even do the same because they might be getting their transfusions on the same schedules. But meeting other children and spending time with other children allows them to recognize that they're not alone, and that, while everyone is different, and, some people have eyes that don't work well, and other people have something in their blood that needs some help, and other kids have lungs that don't work well, who have asthma, there's so many differences. There's some kids that have something that's very similar to you, and having that relationship, both for the parents and the kids, is just immensely beneficial. Anyone who's experienced that relationship would probably be able to, even speak to that. So I think that answers those questions, and if there's not any more, that's the end, right?
Well, thank you so much, Dr. Mednick. That whole presentation was really wonderful. I'm so happy that you were able to share things with us.